So I'd say economics is not something I've thought an awful lot about. But I will say, in thinking about scientific wellness, the clinical trial we're doing with Providence now with 1,000 individuals taking Airveil for 3 years compared against 1,000 normally treated employees for Providence, St. Joseph's, is, I think, going to be a critical and a determinative assessment of, one, improving the quality of health for that set of individuals, but two, a real assessment of how much money this approach of scientific wellness can really save the system. And I think there are many different dimensions to how the system can have money saved. I think one, the idea of keeping people really healthy and not letting them get disease is itself an enormous economic benefit. I think, two, this idea of getting the earliest transition from wellness to disease for many common chronic diseases, and then either treating them with the best approaches we have at hand today, and or being able to design therapies that can reverse them back to normal before they ever get to a disease phenotype. I mean, you can just go for the major diseases and do calculations about how much you could save. I mean, Alzheimer's, for example, it costs for 5 million people, and the numbers is escalating, it costs about $260 billion a year for healthcare, but it costs almost exactly the same amount for caretaking for the individuals that you have to deal with for 5 or 10 or 15 years of their life. And if you apply that to diabetes, if you apply that to cardiovascular diseases, you can tally up interesting numbers. I'll give you another example. One of the most striking examples that came out of the 100 Pioneer Project was the realization that 2 out of the 108 individuals were homozygous for the gene for hemochromatosis, and one of them had blazingly high irons of level and already had the earliest stages of the disease, which is chronic arthritis that prevented him from doing hiking and so forth. And of course, the actionable possibility here is really simple. Take a unit of blood a month until you bring the transfer and the iron level in the blood down to normal, and that reversed his disease beautifully. Now, we find with Airveil, there are actually 9 homozygous individuals, of which 6 have hemochromatosis, but strikingly enough, we find there are 45 heterozygous individuals, and 9 of them have classic hemochromatosis. And this is really interesting because it suggests diseases that are classically dominant recessive Mendelian diseases may well cause the disease in the heterozygous form. There are 5,000 of these diseases, and that's going to be one thing scientific wellness is really going to do in a big way. So I think there are many ways that scientific wellness is going to save money, and we need a 3-year assessment period comparing experimental control population one against another. And I think we'll have really good hard numbers on the types of money that can be saved. And this is important for getting the insurers to start paying for scientific wellness at a point in time where the cost is still prohibitive for lower socioeconomic groups and so forth.
I think we got to get at least 2 questions. So why don't we just go to the second question and we take it later.
I think it's on. My question's about the environmental and lifestyle issues that you sort of show that are 60% of the things that affect your health, or the social determinants, as we talked about. And I wondered how you're characterizing those in your study as part of your sort of holistic, particularly associated with food issues or trauma issues. Is there a way to characterize those?
So the way we characterize those are, one, lifestyle, and that includes your diet and how you eat, and it includes your exercise, and but it also, we measure toxic metals, and we found we have a number of people that have toxic amounts of either mercury, often coming from sushi, eating sushi, tuna, or lead, and we're not sure where that comes from. And all of those cases, you can make measurements about how the environment is impacted. But I'll be the first to say, I think we're just starting to think about the many ways the environment can actually impact health in the context of these studies.
I'm particularly thinking of the ACE study, the Adverse Childhood Experience. You obviously know about that. They came with the conclusion that 60% of current sort of doctor's visits are caused by trauma. That's the primary cause of their visit there and of their disease, the chronic illness. And I just think it's a huge factor, and I'm not hearing that it's being addressed.
So trauma is something we have not really assessed in a methodical kind of way, and I think that is an interesting point.
Thanks.
On that, we're capturing part of that in our global burden of disease estimates. But there is enormous scope to look beyond what we estimate as the health effects of intimate partner violence, child sexual abuse. And this version of the GBD, we're including bullying as a risk for health outcomes for the first time. But there's a whole lot more on emotional, physical abuse in both kids and in adults that could be quantified. It's a very challenging area, and with a large potential for biases to creep in. But we tend not to shy away from challenges. Migration
might even be one that would fit in that category that you have data with already. Yeah.
So I think we have to be more creative in terms of collecting the data that represent the social determinants of health.
Right.
I mean, surveys are not going to cut it because you're not going to get the numbers. So you need to start collecting data from the cell phones. You need to start collecting the data from the way people are using the internet. I mean, those are the ones that are going to really represent the behavior of the patient. So one of the projects that we're involved with is linking the electronic health records data with the census data of where the patient lives, because everyone is represented by the income of your household, by the health literacy of your household, and how are those affecting the outcomes of certain diseases.
Right.
So I think we need to think, I hate the phrase outside the box, in terms of being more creative, in terms of what data to put into the modeling process.
Thank you.
On that, I think what I see as a huge improvement going forward is indeed the ability to link different data sources, administrative health records, social media information, but also to be able to link health surveys where you can ask about exposures to risk factors, link them to the medical records, link them to death certificates, and thus get a much richer picture of what's happening to people over time. And with the advances in linkage methods and electronic medical records, this is becoming possible if you can overcome the enormous barriers that many countries are putting up to accessing any sort of linked data. I think that's one of the biggest challenges. There are a few countries that are way ahead in this. New Zealand, in some parts in the US, but there are lots and lots of countries where it's almost impossible to access systems that are available and could be of great benefit to overall well-being of nations.
Thank you.
Yeah, this is going to be for Dr. Vos. Thank you for your clarification during the break. So your broadcasting model did use 5-level hierarchical modeling, and including parameters at global level, cluster of country, regional, and individual. Could you comment on a different level, what kind of variance we talk about? Because that would be very important for the policy. At each level, global, what percentage of variance it carries and are done to the individual level. This was related to that 60%, 40% kind of concept.
Well, just briefly on this, yes, because our philosophy is that we make estimates even if we have no data for every location, for every disease, for every risk factor. The reason for that is that the alternative is worse. If you say in a country, I know nothing about stroke or I know nothing about depression, and you leave it blank, you're implicitly telling policymakers, don't worry about this one. So we'd rather make estimates, even in the absence of data, by borrowing strength geographically, over time, and through covariates that can predict health outcomes. Of course, those are much more uncertain estimates than you would get when you have a nice time series that is consistent. But that's how we try to deal with it. So the hierarchical modeling is to do that borrowing strength over geography.
Hi, my question is for you, Dr. Hood. I was curious in the PD3 project that you mentioned, like how you guys recruited these pioneers, and with a particular mind towards getting people of different demographics and socioeconomic status and minorities. And one of the reasons for me asking this question is, like, I think that the RVale, startup is a great idea, but right now the cost is really prohibitive for, the average everyday layperson to partake in. And so I was wondering, with that in mind, if RVale is looking at all, like, partnering with certain nonprofits in the area to kind of enroll some people from different communities sort of on a pro bono basis so that they can get educated and learn about the biology and how they can make actionable changes in their life to benefit their wellness.
You should ask that question of Clayton Lewis, the CEO of Aravale, tomorrow, who's giving the final keynote talk. But I will say, with the original 108 pioneers, our entire idea was to try and assess this thing we called scientific wellness. It wasn't to diversify, and in fact, we had to recruit a population that could at least, in part, help pay for it, because we couldn't persuade the federal government to put any money into this. So we essentially started it by philanthropy and by help with a venture capital group. So the pioneers were 21 to 90 plus, with a big middle distribution in the 40s and 50s. Men and women were relatively equally distributed. We had a modest number of non-Caucasian, so there was no attempt to get diversification. What I have done is gone around the country and attempted to recruit, especially in the EU and in Asia, groups to get started in doing scientific wellness. And for example, I succeeded in getting a colleague in Iceland to actually put 150 individuals into this program, and they're just getting to the point where they can analyze the data. And we've begun to agree that we'll be exchanging data and doing this. There are several groups in China that are getting geared up to do scientific wellness. So I think the idea is to recruit local people around the world and then see if you can't get them to agree to exchange the data. But Aravale has some big, new, interesting ideas, and you should ask that question of Clayton tomorrow.
Yeah, I won't be here tomorrow, but I'll ask him at the reception tonight.
Okay, so 2 quick questions, and then we gotta stop.
Okay. So my question is for Leo and Lee. Leo, you talked about the risk and potential cost of over-testing, over-diagnosing. And so in that context, I'm curious to know what you think about what Lee talked about this morning in regards to collecting, tons of data, some of which may not be useful at the time that you're collecting it, or may lead to. Well, I'm just interested in your thoughts on that. And then for Lee, I was wondering what are your thoughts about how to best mitigate against those potential risks?
So the only way we would find out which tests and treatments are not useful is to actually see that it's not useful. So I think we're not going to benefit from the lessons learned, but our children and our great-grandchildren will benefit from all the data that we're collecting now. So my problem with a lot of companies who are saying that we're going to be collecting this and we're going to be improving your health, I think everything is based on stealth research at this point, and you can't be promising that, because at present, as I said earlier, we don't know how to interpret this data. What we need to do now is to collect the data, follow the people who provided their data longitudinally, and see what happens to them. Because I'm just afraid that we're going to be flagging a lot of abnormalities, and all we're doing is increasing their anxiety, which probably is not a good outcome from all this data. But we're not going to get that information unless we collect the unnecessary data now. So hopefully you are contributing to the next generation in improving their healthcare.
So I would just say we went into scientific wellness with 2 objectives. One was to improve the health of individuals, and I think we really succeeded in doing that. And again, I want to stress that the role that the scientific wellness coaches have played in bringing concrete, actionable possibilities to people that from the literature are verified to improve your health and or let you avoid disease. And we have literally thousands of these. As the data grows, so grow the actionable possibilities as you integrate different types of data. The second objective was to generate data clouds that could, when appropriately de-identified, be collectively analyzed together to give you the kind of data I talked about. The correlations that are really going to be transformational, the ability to do estimates of genetic disease risk and various ways to use that. And I think really excitingly, the ability to look at state transitions between wellness and disease. So I think on both counts, the project has been incredibly successful. And we started the scientific wellness with, 400 or 500 actionable possibilities, all of which had come from the literature and been bona fide. So I don't think we've had any trivial, excessive suggestions whatsoever. And this is all, I think, a testimony to the ability to mine the literature and then to get people who really understand this and deliver it in appropriate ways.
Okay.
Can I kind of throw in one other caution? I think, yes, there's enormous potential of doing this work, matching genotype and phenotype information. But apart from the danger of over-diagnosing things that wouldn't cause any problems anyway, I think there's also a great danger of this blowing out to costs. I'm not so optimistic that this will save costs. There's a great potential, and as you know, the history has shown in medicine that any innovation comes with an enormous price tag, and somehow it seems like prices are exponentially growing with everything new that comes onto the market. And particularly in this country that is averse to any regulation of prices, I'd be rather skeptical that this would lead to major savings.
Okay.
Well, I'll just say simply, you're going to be wrong.
Well, excuse me. We've got 2 great world-breaking institutions in Seattle sitting in front of us. So my challenge is to take an example like Alzheimer's, where Lee feels that there could well be some breakthroughs and reduction possibly in that disease over a relatively short period of time compared with the last perhaps 2 or 3 decades. What innovation in those circumstances could the Institute of Health Metrics do to get that type of approach on a worldwide basis?
Not sure you should turn to us. We can quantify this, but we can't, we're not in the business of implementation. There are many, many other peoples who would need to do that. We could provide the sort of compelling information in a way that there would be organizations and governments willing to invest in a new strategy. But yeah, I think you're overestimating what our reach is.
So I think there are a couple of things that could really tremendously expand the scope of scientific wellness. So I think one, we've just scratched the surface on digital health and devices that can do pretty incredible things. I was at a meeting of Amazon in Palm Springs last week, where they had a whole series of leading edge people come and present their latest thoughts about computation and space and healthcare and things like this. And one observation that I saw that was really striking was the ability of a company coming out of Lincoln Labs at MIT to take about 10 seconds of speech from a cell phone and be able to deconvolute it into the ability to assess normal as opposed to depression, the ability to assess normal as opposed to a transition into neurodegenerative diseases. And they were really extrapolating to lots of other kinds of possibilities. Now, I mean, I think the real issue there is kind of signal to noise. Does it really do it that well? It's right at the very beginning, but that is a really exciting proposal. I think a second proposal, again, that's on the digital side of things, is the work that Mike Maresnik has done at UCSF, where he can essentially assess, using computers and asking questions and playing games, a whole series of 10 or 12 major cognitive functions. And once he assesses your weakness, he has a whole series of training experiences where he can buttress the things that you're really missing. Both of these things can be expanded to global scales with billions of people in that particular regard. So I think the other thing, the one thing that absolutely is tough to scale in scientific wellness is the wellness coach. The wellness coach, a good one, can handle 100, 150 people, but if you want to scale to billions, that's a hell of a lot of wellness coaches. So again, I talked with the head of the Alexa program at Amazon, and they're really excited about the idea that avatars could begin to help in scientific wellness coaching. So I think there are real possibilities that can scale to very high levels that take on some of the real challenges for the future.
Okay, great. That was a terrific discussion. Thank you guys very much.